Hello, my name is Sean McCafferty. My collaborator Ken Kilgore and I are presenting sensitivity of Goldmann intraocular pressure predicting progressive retinal nerve fiber layer loss in treated primary open-angle glaucoma. The disclosures are as listed. My only relevant disclosure is CAT stenometer, which is not included in this study, and Reichert, which is a part of this study. In this study, we evaluate the relationship between Goldmann intraocular pressure and progressive retinal nerve fiber layer loss in the primary eye care setting among patients with primary open-angle glaucoma. This was a retrospective cross-sectional study completed in the primary eye clinic. It included 222 eyes in 119 patients. All were diagnosed with primary open-angle glaucoma by a visual field and IOP criteria. The study population included at least 5 serial retinal nerve fiber layer measurements using a spectral domain optical coherence tomographer, which averaged over 4.3 plus or minus 1.4 years. Goldmann IOP, corneal hysteresis, and central cornea thickness were all analyzed in univariate and multivariate models. The results indicated for each increase of 1 millimeter of mercury in Goldmann IOP, this correlated to a retinal nerve fiber layer loss of 0.21 microns per year, which was nearly statistically significant at 0.06. Of particular interest, 133 out of 222, or 60%, of all treated primary open-angle glaucoma eyes showed significant progressive retinal nerve fiber layer loss at greater than 1 micron per year. The fraction of significant progressive retinal nerve fiber layer loss increased to 69% and 75% at greater than 21 millimeters of mercury and 26 millimeters of mercury, respectively. For each decrease of 1 millimeter mercury in corneal hysteresis, this correlated to a retinal nerve fiber layer loss of 0.27 microns per year, and it was statistically significant at 0.02. This correlation approached but was not statistically significant when IOP was included in the multivariate analysis at 0.10. Of note, CCT did not correlate to progression in retinal nerve fiber layer loss among those with treated primary open-angle glaucoma. This agrees with the Jamie Brandt study examining CCT correction in IOP, which does not produce improved results in primary open-angle glaucoma. This does not mean that CCT is not a predictive factor in the diagnosis of primary open-angle glaucoma, as in the OATS study findings. When examining the receiver-operator curve, it indicated a linear correlation to a cutoff indicator of greater than 1 micron per year of loss. And this, of course, is examining the IOP. There's no specific Goldmann IOP that improves the sensitivity and specificity in treating primary open-angle glaucoma. This does not mean that IOP does not have a specific pressure which maximizes sensitivity and specificity in the diagnosis of primary open-angle glaucoma, and in particularly ocular hypertension. In conclusion, Goldmann IOP generally correlates to increased retinal nerve fiber layer loss in treated primary open-angle glaucoma. There is not an ROC curve inflection pressure in which there is a breakpoint for management alteration in treated primary open-angle glaucoma. It is essentially linear. Lower corneal hysteresis generally correlates to increased retinal nerve fiber layer loss in treated primary open-angle glaucoma, but is not entirely independent of intraocular pressure. CCT has a diagnostic predictive value, but not a retinal nerve fiber layer progression predictive value in primary open-angle glaucoma. There are some important takeaways. First, significant retinal nerve fiber layer loss in treated primary open-angle glaucoma should be considered inevitable. Douglas Rhee quoted to me that 50% of treated primary open-angle glaucoma would need incisional surgery in 20 years, and that is reflected in the results that we have here. Intraocular pressure, lower is better for the long haul. Corneal hysteresis is a primary open-angle glaucoma prognostic indicator. Other important takeaways include not missing the boat. We need earlier diagnoses of primary open-angle glaucoma and ocular hypertension, particularly in the young and at risk. Accurate IOP measurement is essential on everyone. It is the only leading indicator in the diagnosis of primary open-angle glaucoma prior to seeing retinal nerve fiber layer loss and visual field changes. Thank you.